I'm Laurie Gutmann, and I've been seeing patients with myotonic dystrophy for decades. And I would like to introduce my colleague, Ann Broderick, who's a palliative medicine physician. But before I let Ann introduce the newest specialty of palliative medicine, I just want to remind you to put your questions, please, in the chat box. And as we go along, we will try to answer as many of the questions as possible. Ann, do you want to talk a little bit about palliative medicine?
Yeah, I'd love to. I think palliative care is the newest specialty, and while it grew out of the hospice movement, it has really grown to mean much more than the palliative than hospice. Palliative care tries to help people with serious illness make sense of our very complex healthcare system. And we do that largely by conversations, by listening, but we also treat symptoms of advanced illness or serious illness. And Paul enumerated them: pain, shortness of breath, nausea, but perhaps most importantly, grief. Patients who develop serious illness frequently are suffering from grief, and it's driving decisions. And important that we address those. Palliative care is always done with a multidisciplinary team: doctors, nurses, social workers, music therapists. That team will also help navigate, help make those decisions, help do advanced care planning. And I happen to think that anybody over 18 should do advanced care planning, so people with myotonic dystrophy should also do advanced care planning simply as a good health intervention. Everything we've said there would be common issues, I think, for people with myotonic dystrophy. Even though I'm not any expert in myotonic dystrophy, it's been my experience that people with serious illness are very similar across the hospital. We don't take over the care, but rather specialty palliative care works with your primary physicians, your specialists, neurologists, cardiologists, ophthalmologists, all to try to hear as best we can from patients and their families what their goals and values are and how their goals and values should drive decision making. We don't want the procedures to drive the decision making. Just because you can do something doesn't mean you should do something. We want more the goals and values to drive what you do. So mostly to emphasize that palliative care is not end-of-life care, but time of diagnosis care to end-of-life care, and it's different from hospice. And you can get it you can get it at the time of diagnosis and say goodbye to your palliative care specialist for a decade or two, and then meet up with them at a later time in life when you have some decisions to make. There's no getting involved in palliative care and then they're attached to you at the hip throughout your life. People come in and out, and I think that's just the character of chronic illness.
Yeah, I think, and in our conversations, it's someone who can come in and take a fresh look and maybe not be so much driven by the disease or the disease process, but really what does the person want? What are your personal goals? So. Right. So I think to try to illustrate this, we're going to go through a couple cases that are made up, but based loosely on real patients that I've seen over the many years, and kind of cobbled them together to kind of give us a feel for how palliative care might help in some of these situations. So the first case that I would present would be Tom. He's a 35-year-old man. He's worked as a social worker for many years. Last year, he had trouble with his vision, so he was diagnosed with cataracts, and his eye doctor referred him to a neurologist because the cataracts were unusual, and he was young. He was diagnosed with myotonic dystrophy. His neurologist found typical myotonia on his exam, and then in the family history, it turns out that Tom's dad died suddenly and unexpectedly at age 45, having had cataracts taken out in his early 30s. So this was this was the history
Typical.
that Tom is looking at.
Mhm.
His neurologist did an EKG and then sent Tom to a cardiologist because there were concerning changes on the EKG. The cardiologist said, you need a pacemaker and a defibrillator. So now Tom, who's just went to get his cataracts out,
Right.
is now faced with a new diagnosis and some significant procedures, and trying to make decisions about, does he want the procedure? What happens if later on down the road he doesn't want the defibrillator or the pacemaker anymore? Those kind of questions for him.
I think this is a great case for a palliative care team or a palliative care physician to see with the neuromuscular team. Imagine yourself in his shoes. He is 35. He's already grieved. His dad probably died when he was relatively young. He's done well, gone to school, now a social worker, and now he's gotten a diagnosis that is has lots of implications to it. I think the benefit, for me, the reason I love being a palliative care physician is I get to sit and hear the patient narrative for enough time to try to understand it. And just listening to that narrative will be therapeutic in terms of his grief. So it will come out that his father died. It will come out that his father probably had myotonic dystrophy. He will talk about his fears of having procedures such as a pacemaker and a defibrillator. That's the best part of my job, is listening to that story. I know you like that part too. So I think addressing grief is very important, but then the next step is helping him identify what his goals and objectives are. I hope that this 35-year-old wants to live as long and as well as he can, but that's my agenda. I need to hear from him. What are his goals, and how can medical science help him meet those goals? And when medical science isn't meeting his goals anymore, what are his options for turning off a defibrillator, and how might that be possible? So I think this might be an appointment that I have over a couple appointments. It might not come all at one time, but it might be an appointment, a referral that I would see. And I'm suspecting we'll also deal with who makes decisions for him, such as if he were unable to make decisions, has he identified somebody who needs to make decisions for him? These are all things that might happen in a palliative care appointment.
I think we have a question here. So the first question here is, I would like to get your opinion on whether or not a G-tube is going beyond palliative care. The goal is to avoid admittance to a nursing home.
So that's a very interesting question. So nothing goes beyond palliative care. So palliative care is the treatment of people with serious illness. So a family or a patient and family who are struggling with whether to put a gastric tube in for feeding, this would be a very appropriate a patient family for us to see. It's a big step to get a G-tube, and it would really depend on the goals and objectives of the patient and the family. If their goals were to live as long as possible outside of a nursing home, and they think a G-tube would help them achieve that goal, we'll explore that with them. So
there also are sometimes questions about, do you have to use the G-tube all the time? Do you have to, some of those can be answered by the gastroenterologist and the neurologist, but there may be some questions that, especially to the person who's doing the procedure, the patient might not feel quite so comfortable, being negative about the procedure.
Correct.
You know what I mean?
No. I think sometimes surgeons ask us to see patients because they're concerned that the patient's goals aren't really being identified, because the patients think the surgeons really want them to do it, and they don't want to look, the patient and family don't want to look ungrateful or negative or obstructionist or a bad patient. So the surgeons say, we're a little concerned that they're ambivalent. They're not sure if they want this procedure. We want to make sure that they're doing it for the right reasons. Can you see the patient?
Yeah.
I'm not sure if we're answering the question of the person answering the question. The goal is to avoid admittance to the nursing home. So if I understand that correctly, a G-tube would be placed so the patient could maybe not need to go into the nursing home. So is it beyond palliative care? No, we have patients who have G-tubes coming and seeing us in the clinic all the time. What your question might be asking is, would hospice support a G-tube if somebody's in hospice? And the answer to that question is, it depends on the hospice. I have to say, in the 99 counties here in Iowa, there's at least 99 different hospices, and they all appear to have very different personalities and admission thoughts. So if whoever wrote that question wants to write a clarifying question, that would be fine.
So let's go to the next case in the meantime.
Okay.
Let's see. So this is a 28-year-old woman. Karen had a baby, and the baby's born having breathing difficulties and difficulties sucking, and breathing difficulties became more difficult. Baby had to be airlifted to a larger hospital where there would be a neonatologist, had to be intubated before they were transported to protect their airway and make sure that the baby survived well. And then the mother has to travel to this other hospital, just having given birth, meets the medical team, and they tell her that they're concerned that the baby has myotonic dystrophy and that they think the mother has myotonic dystrophy and she doesn't know it.
Oh, boy.
So this is something that we see a lot, cases like this where the first time it's diagnosed in the whole family is when a child is born with the sudden expansion of the repeats and has congenital myotonic dystrophy. And so do you want to talk about all the issues there?
So,
because there's a lot there.
There is a lot there. So I'm not a pediatrician, and I don't do pediatric palliative care. We do have specialists here at the University of Iowa who do pediatric palliative care. But I would say the most important thing is to realize that you've just given it, a double whammy is at least fair to say that you've given not only the diagnosis to the mother about her newborn baby, but you also have let her know that she also has a condition that she didn't even know she had.
And she just gave birth.
And all the emotions and hormonal shifts that happen after birth makes her both medically and emotionally needing all the support she can get. Again, I think the same principle is here that was here in the previous case, which is that first and foremost we need to sit, listen, hear, identify grief, overwhelming grief at the concern that this mom will have about her newborn, and then the disquiet that I'm sure she'll have about her own condition and her implications for her health. The key in my experience is that patients and their families, not this newborn necessarily, but they sense the non-abandonment, that is, we're going to answer your questions in the time that you have them and not rush things. This is an overwhelming time anyway. I'm not sure that this mom can absorb or even pronounce myotonic dystrophy. I mean, it's all going to be new.
Right.
And so the first steps are just to take things very, very slowly, not overwhelm, not abandon, and I think that just taking all the time. We often see as children who've been born with disabilities, the families sometimes have guilt, and I think it just needs, those things have to be named and addressed rather than avoided in these settings. And over lifetime, I think that's probably true. Palliative care physicians and teams generally have more time than other specialists. I think it's part of our model is to spend more time, and I think we get to spend the time that many physicians wish they could. And so I think sometimes that's one of our greatest assets, is that we can stay really close, and when other physicians wish they could but need to, are just pulled in lots of different directions.
I think the other role, again, like what we were talking about earlier, is, you know, the safety of talking to someone who's not necessarily part of the care team. In this particular case, they're not the ones who are, you know, you're not the one who's taking care of the baby.
Right.
You're taking care of the concerns of the family, and trying to help them work through what the next steps are. And I think the part what you said about naming it is really important, because it's sometimes we're uncomfortable saying, you know, there's got to be some guilt here. Is there guilt here? Is that what we're dealing with? Are we just dealing with the grief or the fact that it's hard on your family because you've been flown 100 miles away and now you're there with your baby. You may have other children at home. So lots of issues for sure.
So the other thing I would like to say, maybe in the context of this case, is when we were in Washington and did this webinar, someone asked, you know, how many palliative care doctors know about myotonic dystrophy? And I thought it was a fabulous question. And I think the answer is not very many. And then I said laughingly, sort of one, because I felt like I had done some work with Laurie a little bit to know more about myotonic dystrophy. But the truth is that a good palliative care physician, these principles run across all serious illness. If you have heart failure, if you have a different genetic disease, those principles of sitting, listening to the narrative, addressing grief, establishing goals, getting things written down in advance directives, those really cross all serious illness. It's just my privilege to go across the hospital and work with such a variety of kinds of different people. At the end of the day, the patients are just patients and their families nourish my soul. I don't know if that's true for you, but
it is.
Yeah.
Well, let's do another case.
Okay. All right. We're getting no questions yet.
No. But so now we have Mary, and she's a 52-year-old woman with myotonic dystrophy. She's she knows she has had it for a long time, diagnosed a while ago. She goes to the cardiologist because now her EKG has become abnormal. And the cardiologist wants to put a pacemaker in, but she's refusing. And her husband really wants her to have that pacemaker put in. But she had a cardiac cath the year before. She'd had chest pain and ended up having a cardiac catheterization to see if she had coronary artery disease, whether she was at risk for a heart attack. And afterwards she had complications with the groin needle stick, so where they put the needle in to do the cath. She had a lot of pain and a lot of complications afterwards, and she's really anxious about having a procedure that might involve that again. In addition, her brother was found, unfortunately, he had died at home, and his mother found him in his apartment, and apparently he died of a sudden cardiac arrest. So this is all in the that's been in the last month. A year ago was the cath, and she says to the cardiologist, no pacemaker.
Yep. So this is a very typical case, maybe not the most frequent case, but a very typical case for the palliative care team. And it's a little unusual, but I think our skill set can also be helpful here. Mary is refusing. She is 1 month into the grief about the death of a brother who's probably her age, found by their mother. So she's also supporting mother. This is a terrible situation of grief, and very anxious. It is sometimes the role of the palliative care team to listen for long enough that people can identify what their fears are. We can help name what their fears are and what their goals are. This is a person who might, with time, with talking about her grief, the support that she has to be giving her mother for finding her brother deceased. And this is a little bit often story of people not feeling heard. She had an adverse event from a cardiac catheterization, and nobody's listening. So here's a moment where she can get somebody to pay attention to that, how uncomfortable that procedure made, and how now she has a lot of anxiety about ever undergoing a heart procedure. There are ways to manage the anxiety. There are ways to manage the discomfort in the groin. And I think with time, we don't convince her. We try have her convince herself that this is, for her goals, the right thing to do if we can manage the anxiety, if we can manage the groin site discomfort, which can be pretty considerable. Clearly, her husband wants the best for her. What I often do in these situations is ask everybody if our team can just meet with the patient with everybody, but then alone. Coercion plays a huge factor in healthcare, in my opinion. Patients feel coerced from family, they feel coerced from physicians, they feel coerced from guilt. Every mother does things that they don't want to do because they want to please their kids. So there's a lot of coercion going on, and it would just be nice to figure out all of the people involved want the best thing for Mary. I just think Mary needed some time to figure out what her goals and what the best way to achieve her goals. And she also needs to be reassured that if her life, if her goals and values can't be met, then there are options of what to do with a pacemaker and a defibrillator if need be. So yeah. I think it's helpful for her to get back in the driver's seat. She doesn't feel in other patients like this, I just feel like she doesn't feel like she's in the driver's seat.
Right.
And she needs to get back
there.
Right.
She's lost control.
Yeah. Yeah.
This happened, then this happened, then her brother dies, and she's just really lost control, and people are saying, do this, her husband says, do this.
Yeah. Yeah.
And she's lost sight of what she might really want.
Yeah.
So.
Yeah. You want to read that question?
So this is about the PEG tube, and so there's a patient who's being strongly recommended to have a feeding tube because he's weakened to the point that food causes obstruction in his esophagus, and he ends up going to the emergency room. Mm-hmm. And it does sound like they just said that it might be a good idea to see a palliative care doctor to help her husband handle the emotions of the decision. And I think that fits with what you were just saying.
Correct.
Yeah.
Right.
So let's do another case.
Mm-hmm.
So this is Fred. He's a nice man, married, has no children. He's 45 years old. About 15 years ago, he was diagnosed with myotonic dystrophy, and 2 months ago, he had some pulmonary function tests, and his forced vital capacity, which is measuring his ability to blow air out, which means protecting your airway, coughing, those kind of things, it was low.
Mm-hmm.
So today he comes to his primary care doctor's office because he's short of breath for the last week. And they do a chest x-ray and he's got a pneumonia.
Oh, okay.
So the question is, in this case, what would be the next steps in his care?
Mm-hmm. Undoubtedly, we need to treat the pneumonia.
Yes.
So great,
Okay.
great. So there's no question about that. But it is a good time to have a conversation about what, when I talk about goals, what do they want medical science to accomplish, and what would be too much?
Yeah, so for example, this man has pneumonia.
Mm-hmm.
They start him on oral antibiotics, and he's not getting any better.
Okay.
So then he comes in more short of breath. He's now in the emergency room. It's the middle of the night. He's feeling really short of breath. He's going to get put on IV antibiotics. So they're talking about what happens if you can't maintain your oxygenation, and sometimes adding oxygen actually can have the opposite effect in patients with myotonic dystrophy. And so too much oxygen isn't helpful for them. So they say, are you okay with us putting a tube in you?
Got it.
Those kind of questions are going to come
Yep.
up. So
let's go back to the doctor's office, because I think, so he's just diagnosed. This would be the opportune time, before he gets to the emergency room, to have a conversation about, let's just talk about what would be your goals, what's consistent with your values, and what might be too much. So that would be the good time to say, in the event that this progresses and you don't get better because your lung function isn't what it used to be, what should we be doing? And you're sharing some details that I probably want to talk to you more about, Laurie, because I'm not sure what if oxygen acts as a how that might affect,
because of the elevated CO2, so you can turn off the respiratory response.
Okay, right. So I think talking about options in this setting, would it be acceptable to go to the hospital for IV antibiotics right now, early in the diagnosis? In fact, as a former general internist, if I had a patient whose lung function was low, I'd probably go right to IVs anyway. So is it acceptable to go to the hospital for IV antibiotics and maybe transition home? Is it acceptable to get on non-invasive ventilation, such as BiPAP, which is a suction mask over the face? When would it be unacceptable? And have that conversation, and perhaps a family medicine physician wouldn't know how well he might get off non-invasive ventilation, or what would happen if he did get intubated and placed on a ventilator. But these are questions that I think are worthwhile asking at the get-go when somebody has decreased lung function, because they are more apt to have infection. The other issue for him is he's young, married, and I wanted to talk a little bit about advanced directives, if that's okay.
Yeah, that's great.
Right. Many people think that advanced directives, if you've got a spouse, or if you've got a spouse, why do you need to do advanced directives? Well, every state is different, and it's worthwhile knowing, or at least making sure that you're a neurologist and you look up what the laws are on advanced directives. But here in Iowa, by naming your spouse, even though that might be the person that they generally go to anyway, by naming your spouse, you are giving your spouse a higher legal and ethical level of decision making. They are actually making decisions as if they were you. So they can turn down medical therapies, they can say yes to medical therapies based on your goals and values. So I would also be making sure, I hoped that the palliative care physician that saw Fred 15 years ago might have made sure that he got advanced directives. But if he doesn't have advanced directives, I would just pull it right out of my backpack and have him do it right there. Not to make him worried, but to say, I need to know that I'm going to do everything that you want me to do. So naming somebody to be the decision maker if he were ever incapacitated is something that should have been done at diagnosis of any serious illness, not just myotonic dystrophy. But I think in addition, would be worthwhile having a conversation about what would be good for him. The difficulty, as you know, is that patients who have weak muscles get on a respirator, a ventilator. They get weaker because now the ventilator is doing all the work that muscles were doing. So it's
Right.
it's a vicious cycle.
Yeah. And it makes it hard. I think, some of our patients end up on a ventilator without ever realizing that could be a very realistic next step if they get this ill and they get intubated. And it's not the wrong thing. There's no wrong thing here, but the unexpected things
Yes.
are what are so hard. I think that I think, like you said, not having to make these decisions in the emergency room in the middle of the night.
Correct.
I mean, I kind of set you up for that.
Yes, you did. Yeah, that's okay. That's what friends do. So I think the other piece with him, there's nothing that's sweeter for me as a palliative care physician when I meet a family and the patient is in a dire situation, which Fred could come to be, when they say, oh, we've talked about that. We know what he wants. The day that it gives me almost chills to hear that these things have been talked about and it's clear what's needed and what would be inappropriate, what would be too much.
Yeah.
So, all right.
Okay.
Let's just hope the antibiotics work.
Yeah, we'll be. So here's another question. Sorry, I'm not very good at keeping up with these questions, but how can a patient be referred to a palliative care specialist through a neurologist, and does insurance cover this visit?
That's a good question. So you referred.
Yes. And what I know is that anybody can refer to a palliative care. The primary care doctor can. The neurologist can, and the patient, can the patient refer themselves? I guess I don't know the answer to that question.
I think that's different in different places, but I think this is a great question on a variety of levels. Typically, I'm going to make sure that you know the website called getpalliativecare.org. That will describe where palliative care is in your state and in your community.
And that'll be on the last slide, actually.
Oh, good,
so,
good. Just so the usually it's by referral, as it is with many specialists. Some palliative care teams, many palliative care teams have outpatient clinics, and we do. And often a call to them can facilitate a referral as well. I'm going to say one thing that will, I think, resonate or sound familiar to people who treat or who have myotonic dystrophy. I know that you've spent most of your lives teaching physicians about myotonic dystrophy because most physicians don't know much about myotonic dystrophy, which is probably why the diagnosis is sometimes later until people who are familiar recognize it. You may also need to teach your physicians about palliative care. Based on this webinar, you might go and say, I'd like a referral to palliative care. And your doctor might go, no, not that. And you might need to say, no, palliative care is about any serious illness, and we just want the contact with a palliative care physician. So even among physicians, palliative care has been equated with very end of life, even, quote, worse than hospice. So it's supposed to be, while it's supposed to be from the time of diagnosis to a year after the death of a patient, helping to support the family, it turns out that people misunderstand. I'm happy to say that the culture is changing at our institution for sure here at the University of Iowa, but you might get a reaction that's a little surprising, and you might need to say, no, I think palliative care can help me early on, and then maybe not later. I hope that's a long answer to that question, but it's worth getting palliative care involved and establish early on. This isn't about end of life. This is about making sure that I'm adequately having quality, and I'm making decisions that are consistent with my heart, my goals, my values, what makes me, what makes life worth living.
So what about the insurance question?
Oh, yeah, okay, yes. The easy answer is that we're doctors and a team just like everybody else, and we've never had a visit denied by any insurance. So the answer is covered by insurance, and that's never been a problem.
Okay.
Thank you. Right.
So want to do another case?
Yeah. Okay.
Let's see if I can make the slides to work. So this is Michael, and his daughter, 18-year-old daughter, had difficulty. He's 42, and his daughter's 18. She's having difficulty letting go of things, and so she goes to see a neurologist, and she has hand cramps, and but her uncle, so Michael's brother, was diagnosed with myotonic dystrophy, and so she's a little concerned she might have that, and she gets diagnosed with type 1 myotonic dystrophy. So since it's her dad's brother, the question is dad affected? Since so he goes to get his genetic testing, and he's found to have type 1 myotonic dystrophy as well, with a low number of repeats, 80 repeats, and he doesn't have any symptoms. He's never had trouble letting go of things or anything like that, and on exam from the neurologist, he doesn't have any physical signs either, so no signs or symptoms of the disease. But as part of the workup, the evaluation by the neurologist, he gets an EKG, and it shows a significant cardiac conduction problem. So here we are again. He needs to decide. This is somewhat similar to some of the earlier things we've already talked about, but just another scenario, I think. So here's a guy who's completely asymptomatic, and he's now faced with, the EKG question again.
And just as in the other cases, I think we need to give him space to say, I'm not interested in this diagnosis, thanks very much. I'd rather, this might be a good time to talk about denial, that coping strategy that people think we need to convince people not to be in denial, but sometimes that's a great coping strategy for people to move forward with. But we don't want him dying. So we need to give him the options of what does this significant conduction abnormality mean for the length of his life and the quality of his life. I think the biggest concern, of course, is that he might have a sudden death, and it would be our interest as physicians everywhere to have him not have a sudden death if it can be avoided. I see this one as tough because somebody without symptoms really doesn't want to have a diagnosis.
Yeah.
And I would probably spend time supporting that. Again, one hopes that pacemakers, they're major interventions to those who get them, but in the world of saving lives in patients at risk for sudden death, it seems like it would be important to explore what his goals are and his.
Yeah, I mean, I think it's interesting. At least one point I heard from someone that they didn't really want the pacemaker because then they couldn't. This is an interesting one. They couldn't be involved in any of the imaging studies that are research studies that are now where they wanted to be in clinical research studies, so they wanted to hold off from getting the pacemaker so they could be in some of the research studies. I'm not sure how that fits in, but that is something that I've heard. The other thing I would say here now, with this case is that one would hope that before Michael went and got his genetic testing that there was a genetic counselor who talked to him about what the implications of the testing were. Unfortunately, we do see people just, your daughter was diagnosed, and your brother has it, so let's just get your genetic testing and see what you have, see if you've got it too. When, genetically, he had to have it, but it's but there's a real important role here even before we get to the palliative care of the genetic counselor too.
Yeah. So what might the genetic counselor have done here? Just said here are the reasons to do testing and here are the reasons not to do testing. No, I think that would again, this is a little bit about maintaining when you have a serious illness, making sure that you are in the driver's seat. You as the patient are in the driver's seat, or you in conjunction with your family are in the driver's seat of your care.
You're rolling away from me.
Oh dear. Okay. Yes.
Sorry.
Yeah.
Sorry.
We just realized we're
coming off the screen.
Okay.
So I think those were the questions, the primary cases that we had. We haven't gotten any more questions. I think we could ask some of the questions that came up in DC because I thought those were useful. So here's one. Should a palliative care physician be involved when a GI doctor wants to test for everything under the sun? So just to preface that, irritable bowel syndrome or different bowel issues can often precede the diagnosis of myotonic dystrophy or even be a part of the diagnosis of myotonic dystrophy. And many times that's a hard one to try to figure out exactly what's going on.
So I think what the person who asked this question was really asking, is also asking, is when can we have shared decision making about testing? When can I come to the table and say, this is too much for me? And the answer is you always can, but it might help to have a palliative care physician walk you through why the testing is being done and maybe improve communication. One of the things that physicians or families say to us as palliative care physicians, especially on inpatient units, is that we're the connect the dot doctors. We help communicate the communication. And if a GI physician isn't adequately explaining why they want to do tests, sometimes we are helping with that communication. So the answer is yes, if you're feeling frustrated or feeling like your goals are not being met in the healthcare system, I think it's okay for palliative care also to be involved. And maybe this is just a matter of communication because we all think communication has occurred. I'm sure the GI doctor said, oh yeah, I explained it completely, but it's that illusion that communication occurred when it sometimes hasn't. So the answer is yes. Okay.
So actually, just to go back to the previous one with the pacemaker, somebody commented that their son deeply regrets that he was recently implanted with a pacemaker for that reason. He wanted to be included in the brain research and other studies. And I think, that's a noble thing, and that's to want to be involved in research to help
Mm-hmm.
to help others with the disease as well as potentially yourself. But on the other hand, there's the issue of that there are other people who can be in the research, and there are all these other things to consider, including the importance of surviving so you can benefit from the results of the research. It is hard, though, I think, when people really want to be, when people are altruistic and really want to be involved in changing the field, especially at this time when there's so much good research going on, and there hasn't been for a long time. This is kind of an exciting time in the research world for myotonic dystrophy.
And the exclusion is because you can't get in the MRI scanner when you have a pacemaker in place.
I mean, there are MR compatible pacemakers, and so that's something else to talk about when you're talking about whether or not to get a pacemaker. But so I'm just going to do, I think, one more because I think this also reaches out. So one of the questions we got was, how can palliative care help me as a caregiver? So an unaffected parent of a daughter and a granddaughter with myotonic dystrophy, and how do you get started with that?
So I think one of the most humbling parts of my job is the understanding that healthcare in the U.S. is largely done by family caregivers. We think we're doing healthcare as physicians, but it's really the family caregivers who are doing the most of the work. I think it is worth having palliative care involved in large part to see if they can't creatively look at how other resources might be there to help this woman, this grandmother and mother of patients, because what I have found is that frequently there's not the right amount of creativity for help, but there also isn't just the support for the family caregivers. We're doing a study right now simply measuring the impact of palliative care on the patient's well-being, but also on the caregiver's well-being. And I'm very excited about what the potential results are.
So I think we can probably, I think a lot of the other questions were already covered in our discussion.
Yeah.
So maybe we can just wind up.
Yeah. Okay. So I think we just wanted, now that you've heard the cases, to hear what I do every day in conjunction with specialists like Dr. Gutmann. So first, and probably most common on the inpatient side, we address complex decision making. On the outpatient side, I'm far more likely to treat the symptoms of pain, nausea, grief, and address the caregivers who are driving back and forth to university hospitals. But again, emphasize, and if you'd be my palliative care ambassadors to your physicians, to say, no, we think we can get palliative care involved at any time. And we do have more time to listen, help process, and address grief. And I want to emphasize that there is a website that will help you find a palliative care practitioner in your community. And it's not crucial that they understand myotonic dystrophy, because you're not myotonic dystrophy. You're a person, and we really just need to get to know your goals and values and help you weather. You have specialists who understand myotonic dystrophy. We just need to make sure that your goals and values are at the table and you're doing shared decision making.
I think, well, we already did the question. So I think that is it. Maybe we have the website there, and then this just as a recap of this is a recap of the barriers. No, we got one more question. Oh, I don't know how to read this one. Is there a website for the patient caregiver palliative care study where we can sign up.
Oh, well, thank you for that. This, unfortunately, is in patients with advanced lung cancer and gastrointestinal cancer. I'd love to do such a study in myotonic dystrophy. Maybe that's in our future.
It certainly could be.
Yeah.
So once again, here's the website to find a provider near you, and we just want to thank you for your time and your questions. And I think that's all we have.
Thank you very much.
Thank you.
Thank you very much, Dr. Gutmann and Dr. Broderick. That was fantastic, and we learned quite a bit. And thank you, everyone else, for posting your questions. If anything comes up where you have more questions, go ahead and send them over to info@myotonic.org, and we can forward it over to them. I'd be happy to answer any of them as well. You can call the warm line here at the foundation, and I would be happy to do as best as I can to answer any of these questions too. So once again, thank you so much for doing a second edition of your talk for us, one at the conference, and again here, Dr. Broderick and Dr. Gutmann. Once again, to anyone else, this will be available on our website. You can find it through the Digital Academy. We will be posting and publishing it everywhere. So thanks again for joining us, and we will all talk to you soon.
Great. Thank you very much.
Thanks, Paul.
Bye-bye.